So this is, say, a case of button battery ingestion. So I'll be interested to know how many of you have encountered these little things. They're becoming, I think, quite a problem as they turn up in our practice. So this is the story of a 2.5-year-old girl, completely well, no past history whatsoever, and she presented to her local district hospital having said she'd swallowed one of these little button batteries from a television remote control. The first X-ray they took, they almost sent her home. They said, "Oh, it's just an artifact. Someone left something on the X-ray table." And then they did another to be sure. And so there's her button battery stuck in the esophagus, and she was scoped in the local hospital, and that was the picture they took down the esophoscope, and that's the button battery stuck in there, and the sodium hydroxide, which is generated by the electrical current, which is created because the thing is washed in saliva, which really erodes in this case, the posterior wall, because the active electrode was sitting facing backwards. But that was it. The thing was removed, and she was sent home the same day. 3 weeks later, she's been complaining of vague abdominal pains and nausea, but nothing very specific, but then just has a massive life-threatening hematemesis. Blue lighted into the children's hospital and resuscitated, ventilated, and stabilised. Simply and fortunately, the bleeding had settled without having to place a Sangstacken tube or anything such like. And her X-rays, you say, looked pretty unremarkable. So, next investigation. So, what would you think? Would you recommend with that history? We knew she'd ingested a button battery. Yeah, CT. So we did a CT angio. So we took her straight from the intensive care to CT angio. She seemed to be stable. And this is what we found. So typical little berry aneurysm of the mid-descending aorta, exactly where that button battery had been. So immediately taken to theatre. A joint operation between ourselves and the general surgeons with bypass standby, left posterolateral thoracotomy. Found this big inflammatory mass completely obscuring the mid-thoracic aorta, but it was possible to mobilise and control the aorta both above and below, which gave us a little bit more security, and we just allowed her core temperature to cool naturally down to around 33 degrees, then clamped the aorta above and below, and then took down this inflammatory mass. And really what we found, as you could see on the CT, was just this horrid and really complete disruption and a lost full thickness of the anterior aorta, just really held by a paper-thin membrane of clot really over the aorta. So in terms of resection, it was really, you couldn't just bring it together. There wasn't any healthy tissues to bring together. And trying to do a little end-to-end resection, we were worried it was just too much tension. So eventually, really rather reluctantly agreed to put in a small sort of 16mm Dacron graft as a short end-to-end anastomosis. And the general surgeons did a local resection of the esophageal rupture in theatre. But fortunately, she came through it safely. Really made a complete recovery. So returns to the ward, is put on a course of antibiotics for 2 weeks and sent home. And that's the last we knew about her until a year later, where she's been well, had no symptoms, but 1 year later, again, a sudden, massive hematemesis is her primary presentation, requiring resuscitation and rushing to the children's hospital. A chest X-ray, this time perhaps not so benign, what looks like probably some sort of soft tissue mass in the posterior mediastinum. And again, this is her CT angio 1 year later. So an ugly, disrupted-looking descending aorta with a lot of filling defects and a big sort of soft tissue mass around the thoracic aorta. So what next? Well, a pretty heated debate about what we should do. She was stable hemodynamically, no more active bleeding, it seemed, not requiring any further fluids or resuscitation. But eventually the decision was to go to the cath lab. And these were the pictures in angio. So really you're seeing almost exactly what you were seeing on the CT scan, with this ugly really false aneurysm again in the reconstructed descending aorta. Down the AP view, the same. And the cardiologist put in, well, not one covered stent, 2 covered stents to exclude that whole area of the aorta. So successful in the sense that it completely excluded the site of bleeding, but not really successful in terms of how to manage the problem in the long term. So no further bleeding. She's kept sort of nil by mouth, and she has then the next day has an esophagoscopy, but they say they didn't see any kind of ulceration in the esophagus, which seemed unexpected. But she's completely steady, no further bleeding. We feel comfortable that at least the aorta is sealed off. After 48 hours, she returns to the ward and is kept in hospital. And over the next 2 weeks, really, she was completely well, symptomless, maybe the occasional low-grade fever, not being fed. And I guess the patient and her family became less anxious, but I think as the clinicians, we were becoming increasingly anxious of what we should do. We felt we could not leave. This had to be a potentially infected graft, and that leaving her with this was just like sitting on a time bomb. So this kind of debate went on for the next couple of weeks. This is an MRI 2 weeks later, which still looks pretty ugly. It doesn't look safe. There's still tissue, soft tissue mass around the stented aorta. And this was a barium swallow, where again you can see where the esophagus is almost in direct communication with the aorta behind it. But no actual leak. And again, she has another esophagoscopy 2 weeks later, and this is what the general surgeons see at esophagoscopy. They see this nasty sort of granulation tissue with some sort of suture material, and the general surgeons call us and say, I can see a little bit of stitch. This is probably just what the granulation tissue is about. Shall I just pull it out? And we said, no, don't move. Just take your scope out. This is what they can see. They can see some of the coloured suture material on the outside of the stented graft. And we're looking at the aortic, the graft inside the aorta is what we're looking at. So finally the debate was resolved. We said, we just simply cannot leave this girl as she is. And so she goes back to theatre, again through a left thoracotomy again, but with this time sort of with bypass. Again, see the similar sort of pattern. Adhesions fortunately weren't too bad. We could get control of the aorta above and below, but this big inflammatory mass obscuring the mid-thoracic aorta. We went on left heart bypass with 2 arterial lines, one in the sort of mid-thoracic arch and one in the aorta at the diaphragm, and a left atrial single venous cannula, and then felt confident to take down the inflammatory mass. Took out the whole old graft, all the stents you could see, which were really filling the whole thoracic aorta. We'd kind of imagined we would want to reimplant the intercostals. All the intercostals were sealed off because she'd had a covered stent in there for a few weeks. And we used a 16mm gel weave graft to reconstruct the whole intrathoracic aorta. So not really something we'd have wanted to have to do, but we felt we had no other choice given her situation. In terms of her esophagus, the whole mid-portion of the disrupted esophagus that was completely fused to the infected graft was taken out. The esophagus was defunctioned to the right side with a cervical esophagostomy and a gastrostomy to defunction the stomach. So this was the final result with an oversized graft, but we felt we had to try and get something that would provide with a long-term control of and replacement of aorta. And if I run the CT scan, you can sort of see that rather big, ugly graft that goes from the back of the ascending aorta all the way down through the chest here, to the diaphragm virtually. But at least perhaps it got things out in some sort of control. So completely defunctioned. She has the cervical esophagostomy, a gastrostomy. So she was kept in hospital. Fortunately, no neurological deficit through, I guess, luck better than design. And hemodynamically completely stable. Kept on intravenous antibiotics for 6 weeks, and finally sort of sent home. And now it's 9 months later. She's very well. She's a very active young girl, but obviously gastrostomy fed. And the plan is next year to reconstruct her esophagus on the right side of her chest to be completely away from where all the vascular graft is and the reconstruction. So a pretty sad story and a huge sort of insult from just a simple battery ingestion. So I guess for us the lessons were the initial presentation should have been taken more seriously and to recognise how serious the button ingestions can be, and probably should at least have been rescoped a week or 10 days later to assess the esophageal injury. I think when she had the initial operation, when she presented with the hematemesis, she should have been formally defunctioned, at least kept nil by mouth for at least 6 weeks to allow the esophagus to repair and minimise perhaps the risk of a chronic infection. And I guess I'd be interested to see what you think. I guess a covered stent is okay as a kind of salvage operation. It's a fairly sort of quick and reliable way of sealing off the aorta, but obviously it's not really any form of long-term solution. So thank you.
As I said, finished by full recovery.
Not really.
Are there any questions?
Thanks, David. We had a very similar case, and like this, but some important differences. Ours was an 8-year-old girl who swallowed a battery and had presented to Aberdeen Hospital, which is about 2 hours flight from Glasgow, with recurrent hematemesis, which was scoped and then sent home. And then she came in with a massive hemorrhage, and the local surgeons felt obliged to do a left thoracotomy and put a stent tacking tube in to stabilise. So we went up from Glasgow, and this patient had been 6 hours on the operating table. They had put the tube in, stopped the hemorrhage, and she was clinically stable. So our plan was to go through the left chest and use left heart bypass and to deal with whatever we could deal with. And when we got in there, I couldn't get any proximal control. And unbeknown to us, it transpired she had a right aortic arch, and she had a vascular ring, and the battery had basically lodged at the point of the vascular ring.
Very good.
So we had to change strategies, went through the front of the chest, got control, left heart bypass. And what we did different from you is that we were much traumatized by this, but we simply separated the aorta from the esophagus, oversewed, the tissue wasn't healthy, and put some, there was a general surgeon with us, our thoracic surgeon, we put some viable intercostal muscle into pose, and we kept the patient nil by mouth for about 4 or 5 weeks, and she's done fine so far. We have divided. Obviously, we had to divide the vascular ring, but we didn't do anything to the esophagus nor the aorta, except separate the two and put some viable muscle in between.
Yeah.
Thank you, Mark.
Yeah.
Jose?
Yeah, we had a similar case. As you said in your lessons, David, I think you took the esophagus too lightly. And I'm surprised that, the people is just there. It would be nice to suture the esophagus. If you would be willing to use a conservative approach, suturing the esophagus or resecting, but then protecting it with, as we do for lung transplants, with a epiplon or muscle or something in between. Yeah. The other comment is, in our case, the aorta was totally replaced with homograft aorta, because that would eventually give you more chances of ending up with a sterile case. And I'm surprised that you use a synthetic prosthesis, although you dysfunctionalize the esophagus. But anyway, I think the few indications for an homograft, and you can order an homograft aorta even from CareLife or someplace. Now, the stent is a common mistake, because of course you can stop it, the hemorrhage, but you put only more foreign material with Dacron there. So stenting is a common repetitive attitude. But again, this is a very difficult case. I think the homograft could be a solution.
Yeah,
Thank you.
good point.
Alexander, last question.
Thank you. We had a 1-year-old. The problem was a smaller battery. The battery was found and retrieved from the stomach, and then 18 days later came back with, in shock, bleeding. And the problem for us was they couldn't identify where the lesion was, besides underwent endoscopy. And then what I found helpful was MRI finally brought us the solution and could circle where there might be the fistula. The rest of the case, we were much more lucky than you, and we could manage this. But I thought MRI is maybe a helpful tool for visualization of the fistula.
So, this is the message, is that they're getting commoner because the battery technology is changing, and when they get to this size, the 20 mil batteries, they're 3.5 volts, and they didn't used to be that powerful, apparently, so that's why we're seeing more. And if a child under 6 years swallows one of these big batteries, 1 in 8 of them die. Yeah, it's a really nasty lesion.
Thank you.
Yeah.